والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now in this lecture we are going to continue the series of the head and neck imaging. There are two remaining lectures in this series for the time being. The first one is about the imaging of the mandible and the temporomandibular joint, and the second one is about the imaging of head and neck infections. Then the head and neck infection is not yet ready, but we will handle now the imaging of the mandible, and I hope very soon we can present this head and neck infection. And you know that there are a lot of imaging techniques for evaluation of the mandible and the jaw in general, including the conventional X-rays with the panoramic view, as well as the CT scan, MRI, and some of the angiographic techniques, whether performed by CT or MRI. The traditional way for examination of the mandible or primary evaluation of the mandible was the conventional X-rays, and these X-rays were obtained in the frontal view, as you can see here, and in bulbs oblique views for assessment of the left mandibular ramus and condyle, and also the oblique view for assessment of the right mandibular ramus and condyle. And since a very long time we have used this examination, which is the mandibular panorama or the panoramic view of the mandible, which is obtained by a special machine and is considered the simple X-ray of the mandible, where you can have the spreaded view for the mandible from left to right, including the mandibular condyle, the coronoid process on both sides, and the mandibular ramus and the mandibular body. And you can also have a very good idea about the teeth, whether in the mandible or in the alveolar margin. And for a good time we have used also the conventional CT for evaluation of the mandible, and in order to study the mandible by CT we should have the axial and coronal sections, and the axial sections are obtained parallel to the inferior border of the mandible, starting just below the border of the mandible, and we proceed superiorly until we finish or we reach the skull base. In the coronal images, the sections are obtained from posterior to anterior, starting from the region of the temporomandibular joint, and you proceed perpendicular to the inferior border of the mandible until we finish the alveolar margin. The sections are obtained in the range of 3 millimeter slice intervals, and we should have the softened bone window images. We may need to inject contrast material sometimes, and we should ensure in every head and neck study the symmetric patient position to facilitate interpretation of the images. And whenever we have the multi-detector machines, we can obtain the 3D images for the mandible and the zygoma, the alveolar margin as well. As I have mentioned, we should have the soft tissue and the bone window images, and these are usually displayed on the films or on the CDs. This is the difference between the soft tissue, in where you can see the details of the orbit, the details of the brain tissue, while in the bone window images you can better evaluate the lesions containing calcium, such as this chondrosarcoma in the barocellular area, and also you can see the bones of the orbit and the calvarial bones as well, but you are not able to evaluate adequately the soft tissue structures. Now we will have some idea about the anatomy of this area, starting by the axial images, which begin at the inferior border of the mandible and proceed superiorly. This is the symphysis mentae, or the midline part of the mandible, and you go upward and you can see the teeth, and this is the start of the mandibular ramus. Then in this area you can see this is the ramus of the mandible, and this is the styloid process. Here you can see the maxillary sinus on both sides, and this is the bony nasal septum. More above, and you can see better the maxillary antra, the bony nasal septum. This is the ramus of the mandible, and this is the styloid process, and here of course the cervical spine. Then more above upward sections, and you can see the maxillary sinuses, and this is the pterygoid blades. We have discussed in full details the anatomic structure in this area in the lecture of the maxillofacial trauma, and in the lecture of the imaging of the parapharyngeal spaces, and many times we have mentioned that, and also in the imaging of the paranasal sinuses. In here, the maxillary sinus, the zygomatic bone, and this is the mandibular condyle, will articulate with the temporal bone in the region of the temporomandibular joint. And this is the zygomatic arch, maxillary sinus, bony nasal septum, then pterygoid blades, and of course you remember this very narrow space which refers to the pterygopalatine fossa. And in the coronal images, you start from posterior. You can see the temporomandibular joints bilaterally, and this is the head of the mandible, the temporal fossa for the articulation with the head of the mandible. Then this is the sphenoid sinus, this is the ramus of the mandible, the pterygoid blades on both sides. And more anteriorly, and you can see these are the pterygoid blades, this is the ramus of the mandible, and then the sphenoid sinus, and here you can see the region of the hard palate, and this is the bony nasal septum, maxillary sinuses, ethmoidal air cells, orbital cavities, superior orbital wall or orbital roof and the floor. Then some words about the floor of the mouth. We also have mentioned this many times before. You remember this very important midline, almost midline muscle, which is GG, or the genoglossus, and you have two muscles lateral to it, which are the hyoglossus and the styloglossus. Then you see the submandibular salivary gland on both sides, and this is the sternocleidomastoid muscle on both sides. Then if you go further down, then you can see this is the genoglossus muscle, and this submandibular salivary glands, and the sternocleidomastoid muscle. And lower down you will see the muscle which is attached between the mandible and the hyoid bone, and this is the hyoglossus muscle, the submandibular salivary gland, and the sternomastoid muscles. You remember that the multi-detector CT has facilitated the images of complex anatomic areas such as the region of the maxillofacial region, and we have the major advantages of very rapid scanning, the vertical reconstruction, vascular imaging, and the virtual endoscopy. Instead of a single detector in front of the X-ray tube, so we can have more than one detector in front of the tube, and we get the sections according to the number of the detectors in front of the tube. If you have 4 detectors, then you can have 4 sections per tube rotation, then you can have faster scans, and you are able to reconstruct the images in a more better way, and he can evaluate easily the ramus of the mandible. And also you can have the CT panorama, or which is more, of course, detailed anatomic structures obtained by CT compared to those obtained by the plain X-ray. Then you have the facility to reconstruct the images in a 3D fashion or manner, and this is extremely valuable, as I have mentioned before, in evaluation of maxillofacial trauma in particular. But you can also reconstruct the region of the mandible in a 3D way, so that you are able to assess the region of the temporomandibular joint, and you have a good anatomic details, as well as also the pathologic details as well. And this is in a 3D reconstructed image for the mandible, and you can see the ramus of the body, you can see the temporomandibular joint, the coronoid process, and you can rotate the images, of course, as you like. Then you can see the styloid process, you can see the temporomandibular joint, as well as the rest of the mandibular anatomy. And recently we have what is known as cone beam CT, and this is a compact CT machine, which is very small in size, and it uses a cone-shaped X-ray beam and a single 3D or volumetric detector, single detector. And this is the whole machine. The patient chin is here, and the skull and face are in between the tube and the detector. Then one of the important advantages of this machine is the radiation dose, which is 100 times less than that of the regular CT scan. This cone beam CT, the detector, this one, and the tube rotate around the patient head, so that you can have this 3D image for the mandible and the maxillofacial area. Then after you have this 3D image, you can select the desired part to be further evaluated in the axial and the coronal planes, as you can see here. And this is a 2D cone beam CT of the mandible, and you want to look carefully to the area of the mandibular canal, for example. Then you select this area in particular, then the scan will give you more detailed images in the axial, in the coronal, in the sagittal planes, whatever you like, the plane of imaging, and you can have such images. Then cone beam CT is capable only to examine the maxillofacial area in the way I have mentioned, and you can examine the paranasal sinuses, you can examine the mandible, the alveolar margin, and the related structures in bone and soft tissue window settings. Then we are going to handle the mandibular pathology in these three items. Number one, the mandibular cysts and the tumors. Then we'll show some of the miscellaneous conditions. Now, mandibular cysts, and we used to divide the lesions of the mandible as those originating from the odontogenic structures, and others which can occur in the mandible similar to any bone in the human body, which are non-odontogenic cysts. Then the odontogenic cysts include the radicular cyst, the residual cyst, and the dentigerous cyst. The non-odontogenic cysts include the fissural or incisive canal cyst, the Stephan cyst, the simple cyst, and the aneurysmal bone cyst. Then the bone tumors are also subdivided into odontogenic and non-odontogenic. The odontogenic benign tumors include For the most common one is the ameloblastoma, and we have the myxoma and the keratinizing odontogenic tumor or the odontogenic keratocyst. Then we have sclerotic lesions like odontoma and cementoma, and we have mixed sclerotic and osteolytic lesions. Benign non-odontogenic tumors include the osteoma, chondroma, giant cell tumor, any tumor which can occur elsewhere in the body. Then the malignant lesions are also include the odontogenic malignant tumors, which are relatively rare. The tumors extending to the mandible from adjacent areas like the nasopharynx, the oropharynx, the tongue, and the mouth floor. Then mandibular sarcomas, like osteogenic sarcoma, chondrosarcoma, Ewing sarcoma, and the metastatic disease. And these are the mandibular sarcomas, which sometimes seen in the clinical practice, especially the osteosarcoma, but less frequently we see fibrosarcoma, chondrosarcoma, and Ewing sarcoma. Starting by the cysts and starting by the odontogenic cysts, we have the radicular cyst, the residual cyst, and the dentigerous cyst. The radicular cyst arises from the tooth derivatives, and it is intimately related to the root of a tooth which is affected by dental caries. Then if you look here for this classification, we have the three types of cysts. The radicular cyst, which is related to the root of the tooth, the lateral periodontal cyst, which is located between the root of the teeth, and the dentigerous cyst, which is related to the crown of an unerupted tooth, and I will mention. Then this is one of the common lesions, the radicular cyst or periapical cyst, one of the common lesions in the jaw. It may represent about 65% of cysts seen in the mandible, and this is the age incidence, which is between 30 and 50 years of age, and it is considered an inflammatory cyst which is related to the apex of a caries tooth. Then here in this example, you see the apex of this tooth is related to a cystic lesion, and this cyst is in the range of 1 centimeter in diameter. It may be smaller or larger than this, and sometimes you have a cortex for this cyst which is relatively sclerotic, and you see that there may be some abnormalities of the root related to the cyst. Then the residual cyst is applied to any cyst that remains or develops after surgical removal of a tooth. Then you see a cyst here after removal of a tooth, and you may say that this is a residual cyst, and this is also an example. You see the missing teeth here, and this is a residual cyst. Then the dentigerous cyst is one of the common lesions seen in the mandible. It is a painless cystic lesion seen in young adults, and it occurs around the crown of an erupted tooth. And you see this is the unerupted tooth, and you see a cyst which is surrounding the tooth, and by definition the root of the affected tooth should be outside the cyst itself. And this is a good example of a cystic lesion which is related to the crown of an erupted tooth, and typical of a follicular or dentigerous cyst. You use the CT scan with 2D reconstruction, and you see a cystic lesion in the mandibular ramus, which is related to the crown of this unerupted tooth, diagnostic of dentigerous cyst. And as I have mentioned, the root of the affected tooth is usually outside the cyst, and the cyst is related to the crown more or less of the unerupted tooth. This lesion has no extra osseous soft tissue component, and it is a benign lesion and is treated by extraction of the tooth and the removal of the cyst. Then the non-odontogenic cysts, as I have mentioned, include the fissural or incisive canal cyst, the Staphyn cyst, the simple and aneurysmal bone cysts. The incisive canal is this canal which is leading from the floor of the nasal cavity into the palatal surface of the maxilla. And you see here, this is the incisive canal and in the sagittal image, and this is the incisive canal in the coronal image. Sometimes you got a cystic lesion which is related to the site of the incisive canal between the root of the incisive teeth, and this is one of the common lesions seen in the clinical practice and a little bit more common in males, and it appears like swelling in the roof of the mouth, as you can see here, and this is do not involve the root of the related teeth. And this is an example. You see a lesion which is located anteriorly in the midline of the hard palate, and by the occlusal film you see the site of the cyst between the root of the incisive teeth. This is also a good example of this incisive canal cyst, or also known as nasopalatine duct cyst, which is located in the midline of the floor of the mouth anteriorly between the root of the incisive teeth. And you see here the incisors, and you see this is the cystic lesion between the root of the teeth, and it's well defined benign lesion. This is also another example by CT in the sagittal and axial images. The cyst is midline, located in the anterior part of the hard palate, corresponding to the site of the incisive canal. Then similar to any other bone in the body, simple bone cyst, you know, the most common sites for simple bone cyst in the body is the proximal humerus and the proximal femur, but simple bone cyst can occur anywhere and also can affect the mandible. But it is a cyst-like structure, and this cyst is unilocular, and it contains fluid, but from the mandibular panorama or even by CT scan, you are able to see this cystic structure with no internal loculation, and the contents are more or less simple fluid. The value of MRI here is to confirm that the cyst is unilocular and the fluid is serous fluid, not other types of fluid, as we can see. But in the mandibular panorama, just say that this is a unilocular cystic lesion in the mandible, which may contribute to a simple bone cyst. Then this is also another example, and you see as a unilocular simple or cyst-like structure within the mandible, and the related roots of the teeth are intact, and this is may suggest the possibility of a simple bone cyst. Aneurysmal bone cyst is a lesion, also can occur in the mandible. It is an expanding lesion and is multilocular and is characterized by the presence of multiple fluid levels as in the rest of the body. But here you see a big lesion which has eroded the mandibular cortex, and there are loosening of the related teeth. You cannot predict the nature of the lesion from this plain X-rays, and this is an example of a cystic lesion which is related to the root of the teeth. Some of the roots are eroded, then the CT scan showed a big cystic lesion expanding the mandible. There, and in this bone window image, you cannot appreciate the presence of internal fluid levels. But this is one of the main values of MRI actually in evaluation or in helping into the diagnose this aneurysmal bone cyst in the mandible is by the presence of multiple fluid levels within the lesion, and this is classic for aneurysmal bone cyst anywhere in the body. And this lesion affects the right side of the mandible. It's expanding and it contains multiple fluid levels. This is also a good example of an aneurysmal bone cyst in the left mandible, and you can feel sometimes there are internal loculation and multiple fluid levels. This is also a third example of a cystic lesion expanding the left side of the mandible and breaching the cortex. The CT scan showed mixed internal densities and the internal loculations, suggesting the possibility of an aneurysmal bone cyst. And here, if you look carefully, you can see that there is an expanding lesion near the head of the mandible on the right side. These are the 3D images obtained by CT scan, and you can see the internal loculations of the cystic lesion near the involving the mandibular head as well as the mandibular fossa as well. Then MRI T2 weighted images showed mixed signal intensities within the lesion, and this may suggest the possibility of an aneurysmal bone cyst. Then the Staphyn cyst is not a true cyst. It is just an indentation or concavity on the inner aspect of the mandible, and there are theories for the development of this Staphyn cyst. And you see this is the lesion and this is the lesion in another patient. Is the most likely accepted theory is the presence of remnants of the submandibular gland in this area, and this has been histologically proved as a cause for this Staphyn cyst. Then you can see here by CT that this is not a true cyst. It is just a depression on the inner part of the mandibular cortex, which is caused, as they said, by remnants of submandibular salivary tissue here. And this is cone beam CT images for the Staphyn cyst. You see the cyst by the X-ray or the mandibular panorama, and you see the cyst. It is not a true cyst. You see the depression on the inner part of the mandible, and here you can appreciate it in the full image of the mandible, and in the 3D reconstructed image you can also detect the cyst. Now we came to the benign tumors, and of course on top of these benign tumors, we have the odontogenic tumors and then the non-odontogenic tumors. The odontogenic tumors are classified into osteolytic and sclerotic and mixed lesions, and on top of these lesions by far is the ameloblastoma. And the ameloblastoma is a benign lesion, but it is a locally aggressive tumor. Whenever it is excised, it should be removed with a safety margin because of the known high rate of local recurrence. This tumor is considered the second most common odontogenic tumor after the odontoma. And the odontoma is a sclerotic lesion, of course, and this is an osteolytic lesion. Most of the lesions occur in the mandible in the range of 80%, while about 20% occur in the maxilla. And sometimes these lesions are associated with dentigerous cysts and unerupted teeth, and in this condition the diagnosis is usually difficult. Then you know that this lesion, number one, is a locally aggressive lesion. It erodes the related roots of the teeth, and It is a multilocular lesion in most of the cases, although some cases may appear unilocular, but most of the lesions are multilocular, and they are locally aggressive, and whenever they excise, they are surgically removed, there should be a safety margin around the tumor. And if you look carefully here, and you see an expanding osteolytic lesion in the mandible with erosion or destruction of the related or resorption of the related roots of the teeth, and this is one of the suggestive criteria. And here is a multilocular expanding lesion in the body and the angle of the mandible by X-ray and by CT reconstructed image. Then this is also a lesion which is an expanding. It appears unilocular, affecting the mandible, and as I have mentioned, that some of the lesions may appear unilocular by imaging, but most of the lesions are multilocular. This is the range of frequency between the mandible and the maxilla. 80% occur in the mandible and 20% occur in the maxilla, and the age incidence is in the third and between the third and the fifth decades of life. Then look here, and you see an expanding lesion in the mandible, and there is resorption and the erosion of the related roots of the teeth, and whenever it is large, it may erode through the cortex of the mandible, destroy this cortex, and extend into the adjacent soft tissues. Then by CT and MRI, you can see an enhancing papillary solid structures projecting within the lesion. And this is an example of a ameloblastoma in the right side of the mandible with an expansion and the erosion of the cortex and the affection of the related teeth. Then to sum up the basic informations about the ameloblastoma, this is the second most common tumor after odontoma. It affects adults in the third to the fifth decades. It is a single lesion, occurs solitary but not multiple, but most of the lesions are multilocular, and they are locally aggressive, affecting the roots of the related teeth and maybe the cortex of the mandible as well. Then the next type of the benign cystic lesions in the mandible is the odontogenic keratocyst or keratinizing tumor. This is a lesion which is less common in frequency and is seen in a relatively younger age, in the second to the third decades of life. And one of the prominent features of this lesion is that it occurs in multiplicity. Then whenever you see multiple lesions like this, and you can easily exclude the possibility of ameloblastoma. And the second one is this lesion is benign and is not locally aggressive. Then you can see the intact appearance of the related roots of the teeth. Then this is a unilocular lesion. Remember that ameloblastoma is multilocular. Few cases or few percentage occur as unilocular, but this lesion is primarily a unilocular pathology. It contains a cheesy material, and less frequently it may show aggressive characters, but in most of the cases it appears benign. The treatment is the same, similar to ameloblastoma, excision with a safety margin. Then one of the helpful diagnostic criteria for odontogenic keratocyst is the unilocularity, the intact appearance of the roots of the teeth related to the tumor, and also the multiplicity. This is one of the signs that favor the diagnosis of odontogenic keratocyst. And here you can see a cystic lesion with more or less intact appearance of the roots of the related teeth apart from minor erosive changes. And this is also an odontogenic keratocyst, and similar to ameloblastoma, it may be also associated with an impacted tooth, mimicking the appearance of the dentigerous cyst. Then if you look here and you see this is a lesion which is related to the crown of the unerupted tooth, then you will think of a dentigerous cyst. And I will do the same, but in order to reach the diagnosis, then we'll have the biopsy or the diagnosis after surgery. In odontogenic keratocyst is a unilocular disease. It is relatively more benign compared to the ameloblastoma. The roots of the related teeth may appear intact, but you remember sometimes this lesion may have some aggressiveness. But here is a classic appearance of an odontogenic keratocyst, unilocular pathology. The roots of the teeth are more or less intact, and the sclerotic margin is well seen. By CT, the keratocyst is a unilocular pathology with expansion of the mandible, and you can see this appearance with no enhancing projections similar to the ameloblastoma. And this is an odontogenic keratocyst by cone beam CT, the 2D image and the 3D image. And you see a lesion which is almost unilocular, and the related teeth are more or less intact. Then the basic informations about the odontogenic keratocyst include, and this lesion is not as common as the ameloblastoma. This lesion occurs at a younger age compared to ameloblastoma. It occurs in the 2nd to 3rd decades, while ameloblastoma occurs in the 3rd to 5th decades. This lesion may occur in multiplicity, and this is not seen with ameloblastoma. This lesion is basically unilocular, and minor percentage of ameloblastoma occur unilocular. It is in most of the cases is benign with non-aggressive characters, although some of the lesions may show a little bit aggressive characters. Also, you should remember that keratocyst may appear septated, or may have some internal loculations mimicking the distinction from ameloblastoma difficult. And at a time, you can predict, or you may suggest the possibility of the lesion, and if there are overlapping features, you may not be able to reach the diagnosis before surgery. And this third tumor, which is odontogenic myxoma, is a rare tumor representing about 3 to 6% of odontogenic lesions. It is a benign lesion with a slowly growing osteolytic nature. One of the prominent features of this is multilocularity, and it has a similarity to the tennis racket appearance. This lesion is expanding, and it is multilocular with many internal septations simulating the tennis racket appearance, and this lesion may be locally aggressive. And you see here an expanding lesion with multiple internal septations, and by X-ray and by CT scan. This is also an odontogenic myxoma of the left side of the mandible, expanding lesion with multilocular appearance. And this is an odontogenic myxoma in the maxillary side, and you see the more or less similarity to the tennis racket appearance. Then the lesion may be also mistaken for ameloblastoma, but you know that ameloblastoma is the commonest of these group of the lesions, and most of these are are relatively rare compared to the frequency of ameloblastoma. This is an odontogenic myxoma, and you see the multilocularity, which is similar to the tennis racket appearance. Then the prominent features of odontogenic myxoma: number one, this lesion is rare. Number two, it occurs in a younger age than ameloblastoma, and of a similar age like the keratocyst. It is a single lesion, it is multilocular, and it simulates the tennis racket, and it is a locally aggressive tumor. Then we came to the sclerotic lesions, and we have odontoma and odontogenic and cementoma. The odontoma is the most common odontogenic tumor of the mandible. It represents about 66% of the cases, followed by ameloblastoma in the frequency of incidence. The lesion is seen in younger patients in the second decade of life. 50% of the lesions are associated with impacted tooth, and most of the lesions range in the size between 1 to 3 centimeters. They are totally sclerotic. They start by being osteolytic, then later on they became sclerotic. And we have two types which are differentiated only by histopathology: the complex odontoma and the compound odontoma with identifiable tooth components within the lesion. Both types of odontomas cannot be differentiated by imaging. They are only differentiated by histopathology. And this is an odontoma, a sclerotic lesion related to an impacted tooth. And this is also an odontoma, which is a sclerotic lesion related to an impacted tooth. This lesion develops between the roots of the teeth. It is benign but can be locally aggressive. And you may say that most of the lesions affecting the mandible, the common lesions, are usually on the benign side, but they may show local aggressiveness. The lesion starts by being radiolucent, and by time it became radio-opaque, and the treatment is by surgical excision. This is an odontoma, which is a sclerotic lesion related to the root of the smaller teeth. And this is an odontoma, which is a sclerotic lesion related to an erupted tooth. And this is odontoma by gross appearance. And this is odontoma between the root of the teeth. Then the main findings about odontoma that this lesion is the most common. It occurs in children in the second decade of life. It can be multiple. It is solid and sclerotic lesion, commonly related to an impacted tooth like this one, and it can be locally aggressive. Then cementoma is a rare benign tumor. The odontoma is very common, but cementoma is rare, and it affects usually the first mandibular molar. This is the first, the second, and the third, and it is attached to the root of the teeth like this. But odontoma is common and is present between the roots of the teeth. And this is a cementoma or cementoblastoma, the sclerotic lesion which is attached to the root of the tooth. And this is also another lesion, a sclerotic lesion which is attached to the root of the tooth, which is usually the first mandibular molar. And this tumor is rare. It is solid and sclerotic, and is usually attached to the root of the tooth. Then we came to the non-odontogenic tumors like osteoma, chondroma, chondroblastoma, and giant cell tumors. All these lesions can occur anywhere in the body and also can affect the mandible. This is just an example of osteoma of the inner table of the mandible encroaching on the mouth floor. And this is the small osteoma arising from the inner table of the mandible and by the 3D reformatted images. And this lesion is known as, previously it was known as reparative granuloma, but now its name is the central giant cell granuloma. This lesion histologically is just the proliferation of the fibroblasts and giant cells, resulting in an expanding osteolytic lesion in the mandible. And actually it is not known whether it is an inflammatory lesion or a reactive lesion or a true neoplasm or the sequelae of endocrine abnormality. Then this lesion is usually found in children and young adults, and most of the lesions occur before the age of 30 years old. Females are affected 2 times more common than males, and this is an osteolytic expanding lesion of the mandible. Then the mandible is affected 3 times more common than the maxilla. The lesions occurs usually anterior to the first permanent molar tooth, and it can be unilocular and can be multilocular. And here you see the lesion with 2 main histopathologic types, the aggressive one and the non-aggressive one. And this lesion, if you have the histopathology, it may simulate the brown tumor of hyperparathyroidism, and also it may simulate the expanding lesion of the mandible, which is known as the cherubism. Then about giant cell granuloma, this lesion is rare. This lesion occurs in young age and in the children. It is a benign lesion, can be unilocular or multilocular, can be aggressive and non-aggressive. Then cherubism is considered a variant of fibrous dysplasia. There is a severe expanding lesion in the mandible, which is an inherited as autosomal dominant disorder, and this lesion is seen in children in the range of 3 to 4 years old. There is bilateral and symmetrical involvement of the mandible with expansion and multilocular appearance, and sometimes this patient may have this classic appearance, which is upward turning eyes. Expanded, symmetrical, multilocular, cystic lesions of the mandible and maxilla. The related teeth will be loose, and some may show delayed eruption. And you see there is an extensive affection of the mandible by osteolytic lesions with a lot of unerupted teeth. And this is the 3D reconstructed image of an extensive cherubism affecting the mandible and also to a lesser extent the maxilla. You see the cystic appearance with multilocularity. Then cherubism is a rare pathology. It is an autosomal dominant lesion, occurs in children in the range of 3 years old. It is a benign and extensive lesion, multilocular, and very important, this lesion, if left, may heal spontaneously. Then we have mentioned that the giant cell granuloma may have the appearance of cherubism and brown tumors of hyperparathyroidism. Of course, the brown tumors of hyperparathyroidism can appear in the mandible similar to any other parts of the body. These lesions are unilocular and they are expanding, and they contain material which is rich in hemosiderin. Then if you have the MRI in the T1 weighted image, you got the black appearance of the lesion, and in the T2 weighted image you have more dark appearance of the lesion, and if you inject contrast you may got some minor enhancement. Then the major findings for the diagnosis of brown tumors of hyperparathyroidism is the known clinical data of hyperparathyroidism. Then these are multiple lesions in the mandible and in the maxilla, and the lesions showed some healing and sclerosis after removal of the parathyroid adenoma. Then the major issues to be known for the cystic lesions related to the hyperparathyroidism in the mandible is that these lesions are relatively uncommon, they are unilocular, and there should be a clinical and the laboratory evidences of hyperparathyroidism. And one of the major manifestations of hyperparathyroidism in the mandible is loss of the lamina dura of the teeth. And this sclerotic line surrounding the root of the tooth is known as the lamina dura. And because it is made of very fine calcified, very fine calcification, it is one of the most common sites to be affected whenever calcium is removed due to the hyperparathyroidism. And this is a very good example for resorption or loss of the lamina dura in a case of hyperparathyroidism. Then if you see loss of the lamina dura and you see an expanding lesion in the mandible, you may think of brown tumor, and you can investigate the patient for the possibility of hyperparathyroidism. Then finally, we came to the malignant tumors, and the amyloblastoma, for example, may present in a malignant form or a very aggressive destructive form. And here the only way to say that this is malignant is the presence of cortical destruction, extraosseous soft tissue component, and the spread in the adjacent soft tissues. Then at that time, you can say that this is amylocarcinoma or malignant transformation of the amyloblastoma. Then here you see the destruction and you see the extraosseous soft tissue extension, and these are the prominent features of any malignant tumor anywhere in the body: is destructive change in extraosseous spread, periosteal reaction, and the invasion of the adjacent structures. And this amyloblastic carcinoma or amylocarcinoma is considered rare compared to the amyloblastoma, which is very common. And this is an aggressive tumor, and it has a wide range of age group appearance with no sex predilection. This is diagnosed by the appearance of an aggressive lesion with cortical destruction and the invasion of the adjacent soft tissue structures. This, you have seen this lesion before, and this is the reconstructed CT image of the same lesion. An osteosarcoma can occur in the flat bones of the mandible and the calvareal bones as well. And this is one of the common primary malignant tumors in the skeleton after multiple myeloma, and one of the best diagnostic clues for osteosarcoma is the presence of this typical periosteal reaction, which is known as the sun ray speculation. And the sun ray speculation is seen in the soft tissue component of the tumor extending outside the confinement of the affected bone. And this is also a classic appearance of osteosarcoma of the mandible with the radiating sun ray speculations of the periosteal reaction. Osteosarcomas of the mandible represent about 9% of all osteosarcomas elsewhere in the body. And this is classic appearance of osteosarcoma of the mandible with the typical sun ray speculation in the extraosseous soft tissue component. And this is also a classic appearance of an osteosarcoma of the left mandible with the speculations or the sun ray speculations, as you can see here in the bone and in the soft tissue window images. And also metastasis can affect the mandible, and for the diagnosis of metastatic disease, a known history of primary malignancy should be present. Then this patient with carcinoma of the colon, and it has a destructive lesion in the ramus of the mandible representing a metastatic deposit. And here a patient with bronchogenic carcinoma with mass destroying the right mandibular ramus, representing in a metastatic deposit. I will stop here, and I'll continue the imaging of the temporomandibular joint after that. Thank you very much. Wassalamu alaikum wa rahmatullah.